Hey Pete, how do I adjust someone's dose of levothyroxine?
That is a brilliant question. Levothyroxine dose adjustments can be deceptively tricky. Doses are highly individual, and there are certain pitfalls that can catch you out if you're not careful. The first thing to cover is how we monitor thyroid activity in general practice. For most of your patients, this will be done using the thyroid stimulating hormone, or TSH level. The TSH level isn't a measure of thyroid activity, it's a measure of the hormone that tells your thyroid to increase its activity. The best description I was given for this was the TSH is like the accelerator pedal on your car. So to demonstrate this, I've enlisted the help of my colleague, Vin Diesel. The makers of Furious 7 probably didn't realize this, but in the scene where Dominic Toretto and his gang stole the Lycan Hypersport from the Emirates Tower, they were actually providing us with an excellent description of thyroid pathophysiology. If we label the Lycan Hypersport as the patient's thyroid gland, we can see here that despite Vin Diesel providing it with ample levels of TSH, there's limited productive thyroid activity, T4. Other than perhaps this bit where he slaps Jason Statham with the car. This is what's seen in hypothyroidism. At the point of launching the car into air here, we can see Vin Diesel's achieved the desired level of T4 activity, and he can ease off on some of that TSH. This has reached a euthyroid state. After landing in the next tower, though, he realizes the car is now uncontrollably fast. And despite giving an undetectable level of TSH, he's still hurtling towards disaster. And this is a very high T4. This is hyperthyroidism, and if thyroid blocking drugs like carbimazole or propylthiouracil don't slow it down, the patient will sometimes need a total thyroidectomy. So you may ask yourself, how do we avoid this? The management of hyperthyroidism is guided by an endocrinologist, and they'll work with the general surgery team if they feel a thyroidectomy is required. This means that in general practice, we're only really managing hypothyroidism. So let's start with an imaginary patient who's just been diagnosed with hypothyroidism and they require levothyroxine. The BNF advises us that in elderly patients, we should use a starting dose of 25 to 50 micrograms a day. A lot of people might be offended by this, but for the purposes of levothyroxine, elderly is over 65. Sorry, guys. For everyone else, we estimate a starting dose of 1.6 micrograms per kilogram per day, rounded to the nearest 25 micrograms. This means that a 60 kilogram patient will get 100 micrograms, an 80 kilogram 125, and so on. After we've started this, we need to decide when we're going to monitor next. There's lots of flexibility with this, but a patient's TSH level will stabilize in about 3 to 4 weeks of using a particular dose of levothyroxine. So to me, the minimum amount of time we should wait is about 4 weeks. To get a balance between allowing enough time for a dose to stabilize and avoiding delays in reaching the correct level of thyroid activity, my surgeries have decided to monitor this between 4 and 8 weeks after a dose adjustment. But check with your surgery what they prefer. So imagine our patient was started on 100 microgram a day and has had their bloods done. We can divide the results into 3 categories. The TSH might be a bit low, indicating they're overtreated. It could be normal, meaning they're euthyroid, or it could be a bit high, indicating that they might be undertreated. The euthyroid patients can now go to a 12-monthly TSH check, but let's explore the other groups in a bit more detail. Remember that we treat thyroid function to the level, not the symptoms. Symptoms like tiredness are always a complex mix of factors, and there's no convincing argument for chronically over-replacing someone's thyroid function, as this can put them at increased risk of arrhythmias or osteoporosis. This means that for the overtreated example, we'd offer a reduction in their dose to 75 micrograms. When you offer the patient this, they might say, I already tried 75 micrograms and this made me underactive. This is actually quite common, and a lot of people need a mixed dose to hit the right level. This could be 100 micrograms Monday to Thursday and 75 micrograms Friday to Sunday. This will stabilize over 3 to 4 weeks, so don't worry about the ups and downs during each week with these regimes. For the undertreated patient, we first need to check compliance. This could be from forgetting to take the tablets or by taking their levothyroxine with other medicines that might affect the absorption, like calcium or iron. Non-compliance is sometimes difficult to explore with patients, and everyone gets their own way of exploring this, but I generally try to start with a non-judgmental statement like, "It's very easy to miss your tablets when you're busy. How are you getting on with managing yours?" If we're happy with their compliance, then we could increase their dose to 125 micrograms and recheck the TSH in 4 to 8 weeks. Again, if they've already tried this dose, they can use a mixed regime similar to what we described before. This might feel complicated enough, but there's one very important thing to cover before we dive in and adjust doses for our patients. These regimes describe what we do in conventional thyroid dysfunction, but there's dozens of other conditions which don't fit this management plan and require specialist endocrinology input. To illustrate this, in the previous scenario from The Fast and the Furious, if TSH is the throttle, then Vin Diesel is the pituitary gland. If patients have panhypopituitarism, they have little or no ability to raise the TSH in response to low thyroid activity. This means their TSH will always be low, even when their thyroid activity is normal or even underactive. If we were to reduce the dose of thyroxine in these patients, we could cause a lot of problems for them. So this means we need to look at other measures of thyroid function instead. At the other end of the scale, some thyroid cancers require aggressive TSH suppression to reduce the risk of recurrence. So it's important we're careful about these patients too. You might be worrying now how you're going to learn how to manage all these rare thyroid conditions, but the good news is you don't have to, as each of these patients will be managed under endocrinology, and the team there will be able to guide dose adjustments. All you need to ask is, are you under an endocrinologist for your thyroid condition? If they say yes, send the results to them and get on with your life. So we've now got all the tools we need to approach adjusting someone's levothyroxine. When you have an out-of-range TSH result, you should ask your patients, are you under an endocrinologist for your thyroid condition? If the answer is yes, refer to them for advice. If the answer is no, your next question should be, have you tried the dose 25 micrograms higher or lower as appropriate? This lets you tailor the dose to the individual and gives them the best chance of getting their thyroid function in range. This will reduce the risk of arrhythmia, anxiety, and bone disorders by overtreating, or weight gain and depression by undertreating. So there you have it. You now understand how thyroid monitoring works and how to do dose adjustments. See you next time.